Palliative medicine to me, as being a nurse, is truly about advocating for patients and their families. I think it's the one realm of medicine where that's really our entire job, is to make sure patients and families make informed decisions about medical options that they're presented with, and that we advocate for whatever their decision might be. So some families may choose that, yeah, I just want to solely focus on keeping my loved one comfortable. I want to focus on quality over quantity. But there are patients and families that say, no, really quantity is more important to me than quality. Mm-hmm. And even if that may not be the choice we would make for ourselves, it's our job to support them. So depending on the patient and the situation, because they're all unique, we try to involve the patient. We will involve the patient if the patient's able to participate in conversation. So if the patient has capacity and they're communicating with us, we'll sit in the room and we'll ask the patient to have people that help them make decisions or help support them to be there present while we have discussions. And there are other times that we may pull a family into a room like this, a conference room, that's a little more comfortable and everybody can sit down and let them know that they have the opportunity to ask questions. When we as a palliative care team are coming to a family or patient to deliver bad news, we like to use a protocol that was developed by Dr. Buckman in the 80s. And it's actually a model to help deliver bad news. And so by following that, you really make sure that you have the right setting and that you're asking the family and the patient what they understand about what's going on, and that you ask their permission to give them hard news or difficult news so that they're prepared for a hard conversation. And then at that time, you're able to share your medical knowledge and kind of their options and where we are. So one of the things that we hear a lot in regards to feeding and artificial hydration as well is starvation. And families really struggle a lot of times with deciding not to artificially feed or hydrate patients and their loved ones. So we like to say, it's starving if I'm asking to eat or drink and you don't allow me to. But if I'm not asking to eat or drink, if I'm truly not hungry, which is what we see with the majority of our patients that are at the end of life, and that's not starvation. So we try to reassure them they're not doing any harm to their loved one.
Consider this: if you're thinking of a patient who is at end of life and not able to communicate effectively, finish the sentence. If you could speak for that patient to all of the healthcare professionals working with that patient, please consider blank when working with me.
Please consider patients' values and desires and dignity.
Okay. And then conversely, in thinking about healthcare professionals working with this population, finish this sentence: please don't.
Please don't do anything to a patient or for a patient without first giving them options. So we like to say that all hospice is palliative care, because palliative care is about relieving suffering, and that's what we like to do in hospice. But not all palliative care is hospice. Palliative care was really created to help bridge a gap for these patients who have a terminal or an advanced illness, but that aren't ready for hospice yet, or maybe they don't even qualify based on their stage of illness. And so palliative care is really about supporting patients if they're still receiving aggressive therapies. That could be chemotherapies. It could be, they're electing to have tube feedings, artificial hydration. They have not come to the point yet where they're ready to just solely focus on comfort. And that truly makes the difference between what we do in palliative care versus hospice care.